Good morning, everybody. And I'm very thankful to the organizing committee to give me this opportunity to have this presentation today. And the topic of the day is endoscopic management of gastroesophageal reflux disease, their indications and outcome. So in the beginning, first of all, I would like to emphasize the last guideline, which was published in 2013 for the treatment of GERD, and there is no more guideline after that. Probably in 2018 or 19, we will going to have a new guidelines. But in this guideline, I want to emphasize few points which the people usually forget when they refer the patients to us, is that the barium swallow should not be performed to diagnose GERD. This is a very, very basic things that whenever we get a patient, we see that the patient is referred with the barium swallow as a diagnosis of GERD. The second thing is that the diagnosis of GERD is not by barium swallow. The diagnosis of GERD is by pH monitoring. So please do the pH monitoring before sending the patients to have a further investigations or to have a endoscopic therapy. The third thing is that make sure that the patients have got high resolution manometry, and without high resolution manometry, it is basically a major mistake if you send the patients for any interventions without knowing that the patient did not have an achalasia. And we know the patients who are referred to us and the patients had achalasia and the patient was treated as by Nissan fundoplications. So make sure that your patient has got a normal high resolution manometry. Now, the surgical therapy in general is not recommended in patients who do not respond to PPI therapy. And this is a guidelines of 13. I think this is going to change. And endoscopic therapy with transoral incisional-less fundoplications cannot be recommended as an alternative to medical or traditional surgical treatment. And I think this guideline is also going to be changed in this year or next year. So coming to the indications of endoscopic laparoscopic surgery, the first thing is that the patient should have a typical symptoms or esophagitis, and the patient should have a normal high resolution manometry. So these things are the must to make the diagnosis of GERD first. And the second thing is that the patient should have a positive reflex pH study. This is very, very important, and also should have a symptom relation association. So whenever we write a pH report, we always write that whether it is associated with the symptom reflex or not. And this is very much because sometimes you see a patients with functional dyspepsia and they are referred to you and there is no relationship. The other thing is that, which is becoming commoner now, is that the side effects of the PPI is becoming more commoner, and so the people are scared, those who are taking PPI for a long time, so they want to have a surgery or they want to have endoscopic intervention. Refractory GERD and hiatus hernia is definitely an indication, and most of our patients whom we did a strata in King Faisal, they were all patients were having a refractory GERD. Now, the endoscopic device for the treatment of GERD is divided into 4 groups. The one which we use in our hospital is a strata. There is another devices which are used by the injections. There is suturing device, and there is a mucosectomy. So I will come to each of the procedures or each of the devices, and I will see what happened to those devices. So first we will start with injection devices. The first one which came in the scientific committee was the Entrex, which is a biocompatible polymer with a radio-opaque contrast agents. And 6 to 8 ml of Entrex is delivered to the muscularis propria circumferentially without a submucosal or transmural injection. And this was the problem, that how specifically you can inject into the muscularis propria. And the tissue, it rapidly diffuses in the tissue in spongy-moss, and procedure is irreversible. So this was approved by the FDA in 2003. And then after the serious complications from this injection of Entrex, the patient develops pulmonary embolism, pericardial effusions, pericardial tamponade, and this was reported in 2005. And sorry. Back. I'm sorry for that. Again back. Yes. Okay. So no, it's not working, the mouse. So FDA recommendation in 2006 came that Antrax should be recalled, and it is out of the market. Now the second device is the injection device, which we call it a gatekeeper. It was came in practice in 2005, and this is a device where you suck the mucosa into the endoscope, and then you inject the saline, and you make a vacuum, and then you inject the device. And this device goes in a smaller size, and with time, the device becomes larger and larger, and in 24 hours, it becomes dilated, and it blocks the LES. So this one came in the practice in 2005, when there was a paper by Sicola, and they say that this has reduced the significant reflex, and the future of this device also doesn't last for a long time. And there was a prospective randomized trial between a prosthesis and the sham, and they proved that this should not be used because there is not much difference between the sham and the test patients, and also it has got a major complications. So this device is ultimately again out, and FDA disapproved it in 2012. The third one is an injection device called DuraSphere, and it is comprised of carbon-coated beads suspended in a water-based gel, and these are injected into the LES, and the LES become prominent, and then it works as a barrier. But this device was approved by the FDA for fecal incontinence and urethral bulking, and because of its side effects, the device is already approved in 2009, but it was never approved by the FDA for the treatment of GERD, and the people who use it, they use it as an off-label, and also it is out of the practice again. So the fourth one is the plexiglass, and the plexiglass was published in 2001. It was the first device which came in practice, and they found excellent results. The DMASTER score definitely improved a lot. The GERD symptom improved. The fraction time pH improved. But what happened after that no more further trial of this device came, and ultimately the device is not approved by FDA, and device is also out. So now coming to the suturing device. So all the injection devices are gradually out. In the suturing devices, you have got a EndoClinch, Plicator, Isofix X, and Medigas. Now first coming to the EndoClinch, and EndoClinch is placement of threaded sutures at the GE junctions, effectively clinching the junctions to enhance the barrier to reflex. And this is basically suturing of the lower esophageal sphincter. And this device came in practice in 2005, and there was a paper published which shows that the device should be used. And so this was in favor of the device. But after that, there are 3 papers which came against the device, and ultimately the device is also out. So DC by the manufacturer. So now we left with only few devices, and first one of them is the full thickness Plicators, which is still in use, and this is the one which is the paper which has been published with a long-term trial of 1 year, and this shows that this has got a definite reflex, typical reflex decrease, atypical reflex decrease, and it has got a good results. So this is approved, and this is in use still, the full thickness Plicator. The second one which is very important, is a TIF, which is a transoral incisionless fundoplications, and this is approved by the FDA in 2007, And there are a lot of data available for its safety and its efficacy. It creates a full thickness plication in H shape, and this is the TIFF, which is, we call it Isofix X. And this is the report which came of a long-term follow-up of these patients on the last 6 years, and they found that, if you see here that in the blue one is the response, and you see the response from 61 came down to 35, and you see the number of patients who start halving the PPI is increased, but those who stop the PPI doesn't change much. And this is the problem with this device, is that it doesn't last longer. About 40% about 60% of patients continue to have a response, and 40% did not have a response. And just showing the video of this TIFF procedure. Actually, we are not doing it in Saudi Arabia, but I think in near future, in 1 or 2 years, there are a few of our doctors has gone for the training, and I think this is going to be used very soon. So you pass the endoscope into the device, and then you do the stitches in 2 different positions, in anterior and posterior, and you rotate the device. And it takes between 30 to 45 minutes to complete the procedure. Okay. Now this device has done a lot of new generations have formed. They have changed a lot of mechanism, and now in May 12, 2016, they have issued a new generation of the Isofix X. They call it a Isofix X2. And there is also modification is going on continuously. And this is the meta-analysis on systemic review of GERD patients, and all of them goes in favor of the treatment. All the meta-analysis in favor of treatment. But the problem with this, if you see the blue curve, the problem is that slowly it comes down from 70% to 40%. So it is not very long term, but at least it works for 5 to 6 years in patients. And also the American Society of Gastrointestinal Endoscopy approved the TIFF procedure for patients who doesn't want to have fundoplications. So so TIFF is still there, and it is in use. The other one is Medigas, which is made in Israel. It's not available in this country. And this is also a nice procedure. They take 3 centimeters, and they push the endoscope against the endoscope, and they do the stitching of that. And this one into the use in last 3 years. And there is a paper about that in 2016. They changed the GERD HRQL of daily PPI score, and also there is a significant patients who remain out of PPI, which goes to about 70%. So it's basically one of the best one also. So now the STATA procedure, which we do it in our hospital, and we have done quite good number of cases. Has got a very minor complications, and what we have reported is just odynophagia, and we have got epigastric pain. Some patients complain, and bleeding is less than 1%, and none of the patients which we did it who has got a bleeding significantly. And this is the STATA when we do it antegrade. This is the view of antegrade, the upper one, and the lower one is retrograde. And this is the largest meta-analysis which was published last month, and they show that the treatment is favored by majority of trial The advantage with the Strata is that it is used since 2001 until now, so it's almost 16 years, and you have got a lot of experience, a lot of data on the success of this procedure. We did it in our hospital, about 85 patients, and 20% were very satisfied when we asked the patients after 1 year of treatment. 48% were satisfied. There was no change in 17%. Dissatisfied were 11%, and 4% were very dissatisfied. And this is the HRQL score reduced significantly in the last one year in these patients. So this is the summary of the cost effectiveness of all these 4 procedures. And if you see it, that the PPI therapy is $11,000, Strata is $14,000, Nissan is $16,000, and Isofix X is $24,000. The costliest is the TIF. So this is the new technology which came in practice in last 3 years. It's called ARMS, anti-reflux mucosectomy. And this paper was first published in 2014 by Professor Inoue from Japan. And he showed a significant results of improvement in patients who have got ARMS, and they found improvement in the symptoms as well as in the pH fraction, pH. And this is the mucosectomy is very simple. It doesn't need a lot of instruments, and you have just to do suck the mucosa, suck it into the cap.
Dr. Khan, 2 minutes only.
Huh? Okay, and then just cut it. So this is in practice, and in the last DDW, he presented 67 cases, and they found that the improvement is from 61% of patient has got an improvement in 1 year, and it has been a very encouraging results. And I think there is a multi-center trial is going on. So this is the way they do it. They leave about one scope diameter or 2 scope diameters, and rest of them they just do a mucosectomy, and after that it causes contractures and strictures. So this is the way they call it a Mickey Mouse. So they leave 1/3 of sometime 1/3 and 1/4 of the mucosa without a mucosectomy. And so in brief, this is the algorithm for the patients at present in 2018. So what we do that once we have a patient with chronic GERD, we do the EGD, rule out eosinophilic esophagitis or large hiatus hernia. We do impedance pH and manometry, and if everything is positive, then we have got 4 options: fundoplication, Strata, TIF, and ARMS. And those patients who doesn't need a major surgery, we send them for a Strata. Those patients, those places where we have got a technology for TIF, we ask for TIF. And if I think the encouraging result from the mucosectomy is coming up, and in future we will get quite soon, I think it will be available in Kingdom. So in conclusion to the chairman, the patients with refractory GERD now have several less invasive options in addition to laparoscopic surgery. All injectable devices around LES have already been withdrawn. Available successful endoluminal treatment include Strata and Isofix, which is a TIF. And Isofix is much more operator dependent than Strata, is more difficult than Strata basically. Isofix and Strata both improve symptoms of GERD in highly selected patients, and symptomatic improvement in general is short-lived. Although there are few good long-term results, neither showed a significant normalization in objective measures, nor as good as fundoplications. And long-term follow-up results of ARMS are awaited. Thank you very much.